Hello, greetings. I'm Dr. Sahana Baliga, resident in rheumatology from PD Indraja Hospital, Mumbai, under the guidance of Dr. Roni Samant, consultant rheumatologist, PD Indraja Hospital, Mumbai. Will be presenting a case under the title Long-Standing SpA Turned into a Nightmare. Coming to the case per se, this is a case of a 27-year-old gentleman who was diagnosed as a case of ankylosing spondylitis with peripheral arthritis elsewhere since 9 years, presented to us with history of pain in the right midfoot since 2 months. He was on treatment by a rheumatologist. He was put on combination therapy of oral methotrexate, 20 mg per week, and sulfasalazine, 2 gram per day, and on-demand NSAIDs. Patient had pain throughout the day, and it was more on exertion. There was not much of early morning stiffness. On examination, there was tenderness of the right midfoot, no active axial or other peripheral synovitis. Inflammatory markers were normal. X-ray of the right foot was normal. There was no fracture. MRI showed mild tenosynovitis involving the distal peroneus longus tendon. There was no synovitis or osteitis. So he was treated with course of 2 different NSAIDs on 2 subsequent visits along with DMARDs for 2 months. There was no relief at all. So we referred him to an ankle and foot specialist who advised him footwear modification. However, there was no relief. So we advised him bone scan, which showed tracer uptake in the right sacroiliac joint, active inflammation in the right tarsal bone, tarsometatarsal joint, and lateral malleoli, secondary to stress or degeneration. We continued his NSAIDs and we thought of anti-TNF for him. So we called him back with a workup before starting him on biologic. However, he returned back after 2 weeks with severe pain and difficulty in weight bearing, unable to walk. Since his inflammatory markers were normal, we repeated an MRI before starting him on anti-TNF. So this is the image of his right midfoot, the MRI image. First two are in T2, this one is in T1. So what you see is a nice lobulated lesion between the first and the second metatarsal space. Here it's almost abutting the base of the metatarsal bone. This is in T1, there's cortical thinning, and this is the lateral image showing the lobulated mass. So this is a large enhancing lobulated lesion on the plantar aspect uh, of the first and second intertarsal space, abutting the base of first MTP with cortical thinning and altered marrow signal along first MTP. As compared to the previous scan, the lesions along the distal peroneus longus, which was deemed to be tenosynovitis, has increased significantly and now appears to represent a neoplasm, most likely synovial sarcoma. So we referred him to a surgeon, got his biopsy done, which confirmed synovial sarcoma, and he received 6 cycles of chemotherapy along with right below knee amputation. So the take-home message from this case is that a background history of SpA with imaging findings favoring inflammation led to a diagnostic dilemma. Prompt repeat imaging in view of persistent symptoms led to the diagnosis of neoplasm in this patient. Discordance between clinical features, laboratory and imaging findings with no clinical response always calls for revisiting the diagnosis. Thank you so much for the patient listening.